Hi, hello everyone. I hope everyone is having a good evening.
Yeah.
And I know Penang was literally crowded with people this weekend with Diwali celebrations and all. So
Yes.
what I'm going to do is I'm just going to just give you a hint on what is my field and how we help out women in ways possible. So I'm just going to share my slides here.
Okay, there we are. Yep.
Yeah, this is going to be my outline. I'm just going to give you just a brief introduction as to what I do and what are the conditions that I look in my practice, some investigative results, some of the approaches that we have, and the teams that we get involved with, inclusive of the preventive care and education, as well as the innovations that are there. Right. So basically, when you talk about urogynecology, majority of the women believe, oh, urogynecology, what is this all about? What are we actually dealing with? So the Americans got it right when they called it as a female pelvic medicine and reconstructive surgeon. So I remember stating this in one of Karen's podcasts, and she was like, "Reconstructive surgeon, Sashi, what are you reconstructing down there?" So, so basically, what we do is we complete our medical studies, and then we go into becoming specialists in obstetrics and gynecology. So once we're done with that, this is a specialty where we tend to deal with everything vaginally. We are pretty much the vaginal doctors. So anything that is affecting a woman in the vaginal surface, we are the doctors who deal with. So, in reference to the urologist, majority of the urologists do this work, but the anatomy and the things that are surrounding the female genital tract is rather different in comparison to what the urologists have to offer, and this is why the specialty came in a big way. So when we look at continence per se, there are different types of continence. One being stress incontinence, whereby when you laugh, cough, sneeze, there's pressure over the bladder, and the pressure leads you to have leakage of urine. The majority of the time is what women suffer from is urgency, where they rush to the toilet, and as soon as they rush to the toilet, they feel that some women are able to hold their urine, some women are unable to hold their urine, and that causes them to have some amount of leakage. And then there is also the neurogenic type, whereby it's already a nerve involvement. There might be degeneration that has occurred in the spine, or degenerative symptoms that has led a woman to end up having some sort of incontinence. So these are all the parts that we deal with. The second part we deal with is pelvic organ prolapse. So what is pelvic organ prolapse is, if you look at the first slide above here, you can realize in terminologies what we call as the juto, your yingtao, your qigong, and your pangsai area. So the vagina, bladder, uterus, and this is what happens. So majority of women post delivery or suffering from chronic constipation, or when they are in their menopausal state, they can have different parts of their things, masses coming out of the vagina. And believe it or not, this is not cancerous. This is not something sinister. It is just weakness of the bladder floor or the rectal floor or the uterine pelvic floor muscles that has led to this. So this would what we see. If can you see my arrow
Yes.
here? Yeah. So if you see this arrow here, this is what we call a cystocele, whereby the bladder has dropped, which also gives a mass. This is a rectocele, where part of the bowel and where we poo, this is where we poo, and that part is moving outwards. This is where a womb has prolapsed, whereby this is the uterus, and the uterus is coming down all the way outside to the vagina. So then they believe that, doctor, it's all right. I've already underwent hysterectomy way before. I should be fine. Nothing can come out. So this is post hysterectomy. This is what this is what the structures is supposed to look like. Your bladder here, your where you open your bowels here, and the vagina being said. But certain women, what can happen? This vagina can end up prolapsing down too, leading to another problem. So, like what Karen had said, quite a lot of problems in a very tiny space.
We won the lottery, yeah.
So this is it. So majority of the time, how do we deal with this? We have this sort of conservative management whereby we put in a small sort of a ring. So what we say, your partners will give you one ring, and us urogynecologists will give you another. So we place it a sort of a ring. It just looks like a really nice silicone-based ring that you place inside. And this is what we call as a ring pessary. This may help push up the uterus up there and keep it right there in its position. And for those who has really, really advanced prolapse, there is another space occupying ring that is available that we can place on the inner aspect. So when we are talking about this surgery-wise, majority of our surgery is actually done vaginally. So that is in comparison to latest technique where they have a very, very big scars on the abdomen, or you tend to have laparoscopic scars, holes in and around your tummy. This surgery is all done vaginally, and we are able to fix everything up and pretty much make you younger again. And so when we look back at, and there are certain conditions whereby, as you can see over here, this is a large fibroid that is there. But as long as we are able to gain access from down below, we are able to even pull out the small fibroids. Fibroids are like benign muscles that develops in the uterus, and we are able to pull it out all vaginally at the same time and fix everything. So if you look around, this is my favorite slide whenever I'm I'm talking to any of my patients for surgery. If you see the abdominal surgery, you have a nice cut over here. Robotic surgery, like we say, is technologically proven. It has around 3 holes going this way and another 2 holes going that way. Laparoscopic surgery has holes in this way. Even with advancements of laparoscopic, you can do it in 2 holes or even in 1 holes. But if you see the vaginal surgeon right here, no whatsoever scars over the abdominal cavity. So with this, we find it a little bit superior so that once we do the operation, the women are back to their homes even faster. So other than this, the next step is urinary tract infection, and a couple of women do suffer from majority infections which are not healing off, and this can have a profound effect due to the bladder as to how the bladder pathology, bladder microbiomes are, or even the vaginal microbiomes are, which causes them to have recurrent urinary tract infection. And this is something that we deal in our practice too. The other thing is during deliveries, as you can see, if you have had a vaginal delivery, majority of the time, if you can see my arrow here, there is one baby's head that is coming up, and these are all the muscles that are involved, and these are all the muscles that are getting stretched. So there are tests that can go all the way down to your back passage, whereby it causes you to have difficulty in holding your motion or holding your flatus, and these are the things on what we can do to help improve improve symptoms for patients. Then the other than that, this is another what you call important problem that women has been suffering from chronic pelvic pain, whereby they have pain all the way in the aspect of the muscles of the pelvic cavity, and usually these are all the causes of it, but it can go into spasms, and these spasms can be very debilitating for the patients because they tend to take a lot of painkillers. They are majority of the time find it very difficult to walk in and about and around, and so we tend to sit and teach them on what are the steps you can take to reduce that sort of spasm that is occurring in the pelvic cavity after we have ruled out all these six causes. Then vaginal atrophy, I think this one is where Karen pretty much is a advocate in, whereby as
Yes.
the aging process occurs, estrogen levels in the drop, and due to that there are changes. So this is a very nice and luscious mucosa that we are looking out, and during atrophy this is what occurs, and this leads to majority of it. It's like pretty much how do you differentiate? You differentiate it as a nice, beautiful island with water and mountain and greenery, and the other is the Sahara Desert altogether. So
It's
being in the
dryness.
Sahara
It's
Desert,
dryness.
yeah, and that dryness is it. So atrophic vagina is what majority of times I tell my patients is this is just like sandpaper in comparison to how the skin should be inside your mouth cavity, which is nice and soft and smooth. It turns into sandpaper, and this is what causes majority of the symptoms for the patient of dryness.
It
Yeah.
also feels like sandpaper when it's dry. Just so
Yes.
you know how it feels.
Yes. Yes. I do know that. I do know that. So then the other part is now with the younger generation group of women, the majority of them suffering from sexual dysfunction, and they find it a little difficult to be intimate because it's the pain and it's the what you call the opening might not be wide enough for penetrative sexual intercourse, and this leads to them having quite a lot of problems finding themselves a partner and being close to that partner. In the older age, I mean, in the what you call aging group, majority of time this dryness ends up sitting and causing small bands in and around, and that causes women to have pain during sexual intercourse, and this is one problem. And there are ways on how either we can do surgery, or we can give them certain injections, or work things out after our assessment around that. So this is something new that has come up and now budding in our practice, which is cosmetic part of the gynecology that we are dealing with. This is in hereby whereby majority of women, they like the what you call opening of the vagina to look like a Barbie doll sort of a feature, and they don't like all the skins that are flapping. I do come across quite a lot of women whereby when they pee, it tends to splash in and around, and that kind of cause it causes it to be a little too difficult for them to pass urine freely, and this may be due to the excessive skin growth that has occurred in and around. So it's a very short surgery that what we can do, and we can fix the area up, and within 3 to 6 months you can end up having it looking wild and thing. And for those who have had vaginal deliveries way before, majority of the time the opening can go all the way down, and this is something that we do to fix it and make you all feel younger again. And this
It's,
is something, yeah.
sorry, is it because of the tear, Dr. Sasi, when we
Oh,
child?
it's not really due to tears, because I think the youngest girl that I came across was 14 years old and she was not sexually active. So what happens is majority of times is the wear, whatever clothes that you wear, or the underpants that you wear, or you get injured, or the brushing and the constant irritation at that area that allows the labia to elongate. And we
Oh,
Asians are very prone to have that.
sorry.
Yeah. Uh, so we have quite a generation of women who tend to have a little bit longer than ever labia, which can be thing. But doing this surgery, I would highlight this to you that we don't do it for every patient, because this labia excessive skin that is there can be protective in preventing the dryness too. But on an experienced person who takes a little bit too much, the dryness will start at the time as the patient heals. So this is something that is we are offering in our practice too. So as we are going, so these are uh, um, okay. So the other part is when it comes to our field per se, the standard ultrasound that is being performed with all your gynae is pretty much that. But what do I bring additional to the table is I tend to look at your bladders if you have a bladder problem that is there, in case there are any minute skin that is growing or stones that are inside that we'll be able to catch up. And we also do a kidney scan to take a look at how the kidneys are, especially if you have a pelvic organ prolapse or recurrent urinary tract infection. This tends to aid us whether or not there are small infections sitting in the kidneys that needs to be dealt with. Um, this is a very, very brand new type of scans that is currently picking up in the market, and it's done by majority of the urogynecologists, whereby we place in a small probe. This is the probe, and we place it just over the vagina, and with that we are able to catch all these muscles. Can you see over on the right all these muscles? Whether or not all these muscles are actually working really well? Are they strong? Are they functioning, or have they undergone micro tears or any tears during childbirth? And this may cause problems with sexual function, whereby a woman post delivery might find it difficult achieving orgasms, or she might find that she's a little bit too loose down below, why it doesn't feel the same way before. And these are the things now that we can catch up with it. So as you can see here, these are a couple of pictures that tells to us, like, for this sort of patients, you can see that she had a test. She had a 3.8 kilo baby that she delivered vaginally, and it tore. So over a period of time, then she came to me saying, "Oh, doc, I don't feel my sensation anymore. I don't feel that sort of feeling that I used to feel on achieving my orgasms compared to before." So we are able to structurally tell them what is wrong with them, and probably look about on what are the treatment modalities that are available from there onwards. So then this is a test we do for a quantitative test we do for women with problems with bladder, whereby when their bladder is overworking and it's being a very, very naughty child, making them having urgency. This is one of the tests that we can offer for them. And the other part of the imaging that we do is we also do a small camera test, take a look into the bladder to see if there's any infection, function. These things can be done outpatient or usually during the procedure per se. For those who have continuous leakage post-surgery, there are ways where we can take an X-ray over them, and we can relocate from the whole kidney all the way down to the bladder to see if there's any functional problems that are there, which you can see. You can see a nice system of where the dye is just coming all the way into the bladder, showcasing everything is doing fine. So so then, when we are looking at the approaches, there are approaches where I guess most of the emphasis on why my Karen is here, and I'm with Karen here today, is majority of the lifestyle modification and pelvic floor therapy that we can do in order to improve that before leading to medication or surgical intervention. So the pretty much is physiotherapist. We can help you out on how to do the exercises properly and get you to a physiotherapist who will tell you, okay, these are the muscles that you need to squeeze, and these are the muscles you should relax during the period, during your days. And then there are also majority of psychological and emotional support groups. These are all from foreign countries, and I think this is something that Karen is advocating in her practice. And
Yeah.
because majority of the women out here, they tend to see a TikTok video and say, okay, let me try doing this, and whether it works or it doesn't work is different, because there's no follow up to that. I think this is very important because this way we are able to educate more and we are able to create the awareness that is important in highlighting these pelvic floor dysfunctional problems. So these surgeries, some of the surgeries whereby they have an abdominal hole within the bladder that is experiencing into the vagina, and this causes women to have constant leakage. So majority of the time we either have a collaboration with the urologist and get this thing done. The same way, if it's a hole down below where the patients are having poo coming out of the vagina, majority of the time, yeah, such problems do occur. So we are able to correlate with the colorectal surgeon and help sort this problem out. You wouldn't believe me or not, majority of women do suffer from this, but they tend to be silent about it.
Sorry,
So
Doc, can I
yeah,
ask on behalf? So you're saying that even when it can be not just urine flow, but even feces that can,
yeah. So through the vagina. So as you can see here, where I placed the urologist, this is a young girl who delivered, and she during her delivery time, what had happened is she developed an injury down below, and this injury can occur during surgery or it can occur during vaginal delivery. It's pretty rare, but when it does occur, she can develop constant urine. That means once the kidneys produce urine, it goes through the passage into the bladder, and there's constant urination coming out of it. It can be very debilitating to a woman and poor quality
yeah,
of life. But this fistulas that you're looking at here, these are majority of the time caused by normal delivery. The chances of it occurring is very low. However, if it does occur, uh, what majority of women do, they get very embarrassed that such a thing is occurring. They tend to have what you call air passing out through the vagina, or they have feces coming out of the vagina. And so what they do, they tend to constipate themselves, go to the toilet probably once or twice a week in order to create that to prevent the problem. And these sort of problems tend to cause women to stop going out, stop socializing, stop doing what they do. And you'll be surprised to see that there are quite a lot of women who suffer from these problems. So, so mainstay pelvic floor exercises, Kegels exercise, it's there for women. It's important. I think doing the exercises is important. And if the exercise is not working per se, then probably a follow-up with us would help you isolate which are the muscles that you need to contract upon and help clear the situation. And so Kegels is not only for women, it's also for men.
yeah.
And so once you're doing, and Kegels is something, it's like how I mentioned to Karen during our talk once, as I'm talking to you, I'm doing my Kegels exercise. Majority of the people don't know, but it's sort of an exercise that's very good for your pelvic health. So then, patient education, I think these are important. Here we have this thing called as an Ayuga, Your Pelvis Floor website, where they have quite a lot of information leaflets. So I tend to use these information leaflets to help out. As you can see, this is a international society, so we got all the information in English, in Chinese, in Indonesian, in Malay, whichever language is required and needed, depending on which are the patients who come to us. And then for innovations, right now there are a lot of devices that you can buy on Shopee and you can buy on Lazada, where these are small, minute probes that you place within your vajayjay, and it delivers a little current that helps squeeze the pelvic floor muscles. My only request to you, if you are using any of this device, it is important for you to get a physiotherapist or get us to assist you in this, because these devices, what they do, they tend to facilitate passive contraction. And what is important is, in order to build muscle, you need to actively contract. Passive contraction does not usually build muscle and build strength.
Mm.
So this is a very nice, interesting app, which is we call the Squeezy app, and this is in the NHS in the UK where I work, where majority of the women can download this app, and it will tell you, and it will send a buzzer to your phone. Okay, time to squeeze on a day-to-day basis, and it updates your Samsung or your i watches, telling you, okay, it's time for you to squeeze. So these are the things available. So this is another thing that has come up in a big way, which is laser therapy, whereby majority of women, in order to there are many clinics over there that facilitate saying, okay, for pelvic health and thing, we have this sort of laser, and this laser, we place it inside, and it can sit and improve your dryness, improve the quality of the tissues down below, improve the incontinence that are there. But for this services, according to all the trials and studies, and even on expert opinions on those using it, it's very, very selective. There is uh, uh, 20 to I mean 30 to 40% of women that actually benefit from that, and majority of them don't benefit of it from it. And this sort of therapy can be expensive, and it requires therapy for only a certain select group of people and not all women. So if you
Doctor,
have a, yeah.
is this treatment covered by insurance?
No, no, it's not covered by insurance. So
Mm.
this treatment is majority of the time you have to pay on your own for it. Majority of the clinics here in Malaysia, on the aesthetic clinics as well as the beauty clinics, are giving this therapy, but uh, it's very, very selective. Not every woman. I can probably give you a ballpark that 70 to 80% of women might not benefit from it. It's only the 20% of women benefit from it
So
per se.
maybe is it due to age or health concern? Then they would, do they,
Uh,
is that how they criteria it?
uh, so Karen, when we talk about vaginal health, there are certain parts of the skin that is sagging and the muscles that are weak.
Okay.
So these lasers, they penetrate 4 millimeters. 4 millimeters is very, very small. So
Mm,
they give a very, very good local sort of irritation, just like how you get injections of
yeah,
Botox over the face, the
yeah.
same way over the area, and
Mm,
they're expecting tightening. But majority of the time, 4 millimeters, you'll need at least 1 to 2 centimeters of tissue that needs to get involved for it to actually give that sort of service. But these sort of lasers and RF and whatever that is there in the market, they are not licensed to go higher than that, because then they might cause problems and cause that sort of leakage what we were talking about before,
okay.
uh, cause real actual damage. So
Yeah.
then this is another thing that has come up to the market. I think the same Botox, the same PRP that a majority of women are placing over the face, yeah, we tend to use that also in the vagina for chronic cases whereby we tried employing the normal therapy of giving them hormones, estrogen, hyaluronic acid, and those skin over the vagina is not building up. So this is the time we go to an alternate approach of placing PRP in hopes of redeveloping the skin down below and keeping them happy back again. So then advancements, the other thing is doing surgery laparoscopically, but through the vagina per se, and removing what you call wombs or ovarian, I mean, any cysts that are inside this and around. Uh, this is something that currently quite a lot of specialists in and around are practicing, because they are avoiding any sort of scars and bump. As you can say, once you have those sort of scars, you tend to be very shy going to the swimming pool or heading off to the beach side with your bikini or what sort of wear. So this is some sort of therapy that is available in order to remove whatever problems that are there within the womb or in the cavity through the natural orifice. So, and then the final thing is robotic surgery. This is also a new thing that has come up in a big way in the market. But pertaining to our field, as you can see over here, this is the vagina, and majority of them, they do have a technique whereby they place a small mesh and they hook it to the bony part of the inner part of the pelvis, and they place the mesh and they attach it to the vagina in hopes of keeping the vagina at its present. Um, uh, there are a few of them in KL who do these operations. I per se, I do all my surgeries vaginally, and I'm able to preserve it vaginally. As you go along, I guess in your field, there are techniques that you can use to improve and make things easy. So then, pretty much, yeah. So the take-home message is, I guess, at the end of the day, is early diagnosis leading to a better outcome. There's conservative and surgical. Majority of the time, when a patient lands up with me, I tend to go on the conservative route depending on what the problem is there, and then move towards it. Uh, the open conversation, I think this is something that Karen is actually doing, and I think it has been very, very helpful in all of us bringing out the awareness that is needed and available and needed in pelvic floor health. Because I was talking to one of the surgeons the other day, and what he told me suddenly just gave me a eureka moment. It seems that urinary incontinence for a woman after the age of 50, where she's unable to control her urine, is pampers. And they believe that is all that they need. That is the only treatment that is available. And there's nothing else that we can offer and we can do. So this talks and this awareness is very, very important in opening dialogues and creating bridges and bringing down barriers that are there. And so yeah, I guess this would be the last slide, which I'm going to end with.
Okay, so I'm just going to read out some of the poll that so a large number of women want to know that they have this problem where they rush to the toilet quite a bit. And I did explain it's also due to the weakening of your, the pelvic area and all that. So, so could you explain what they could do to monitor or improve the situation?
All right, so what usually occurs is it doesn't occur just the next day, it's something that goes on very, very slowly.
Yeah.
You start off by feeling, okay, I used to go to the toilet probably 3 to 4 hours. Now I'm going to the toilet a little bit more
Yeah.
earlier than ever. And then you realize that the frequency starts increasing. The frequency goes in from like 6 times a day down to 8 times, down to 10 times. There are some group of women whereby they see that after 12 o'clock, as soon as they fall asleep, and that's when they start rushing to the toilet, and 4 to 5 times they're going to the toilet, which is very poor for quality of life. So the most important question that I guess you have to ask is you have to know that these are the changes that are occurring in you that that leads you to saying, okay, right now I do have a problem. These subtle changes do not occur within 2 months or
Yeah.
3 months or overnight. It takes a really long time for it to personally develop. And when it develops, that's when we start to think, maybe I'm doing things differently. Maybe I'm eating something wrong, or maybe I'm practicing, doing something wrong. And that's what has led to this. So from there, how you go about it is um, it depends on where your leakage is, whether the leakage is actually leakage when you're coughing, laughing, sneezing, or lifting something heavy, or the leakage is occurring because of the urgency. The practice is initially I was able to hold till I reach the toilet, but now and I'm unable to hold my urine at all. So the treatment what we offer for these two group of people are totally different.
Right.
For one group of people whereby the laughing, coughing, sneezing, lifting heavy weights, the sort of lifestyle that you need to change would be stop lifting heavy weights, stop exerting yourself in a little bit in that manner, start doing your Kegels exercise, and these are the ways that are going to sit and help bring down the symptoms that are there. And for urgency, whereby you're rushing to the toilet, you're unable to hold, for those sort of women with symptoms, that is a different ballpark altogether. Uh, First, we need to rule out whether they are having any urinary tract infection. And I guess if you visit any GP, they would do a urine test and tell you whether you're having infection or not. So during the infection, if you're having the symptoms, it's null and void. You need to clear the infection first. If let's say there is no infection going on and you're having these symptoms, then it's on to looking at lifestyle modification on what are the triggers that cause the bladder to go into this sort of thing. So pretty much what it is as women develop they go into perimenopausal and menopausal state, there is a very important layer in the bladder, which I call it the waterproofing, or in medical terminology, is called the gag layer. When that gag layer tends to get disrupted, that's when all the symptoms start uh, becoming a problem.
Okay.
So the things what we do for urgency is totally different. I tell them to avoid try going to the toilet. When you're passing urine, you have to pass urine twice rather than passing urine once. That means you sit down, pass urine, then you get up, probably do a 2, 3 hip shakes, and then you take another sit on the throne and pass urine again. That will help empty your bladder totally and
Right.
probably avoid all the triggers. And the triggers would be all the common things that I guess all the women here love. That's your coffee, your tea, fizzy drinks, juices, especially lemon, lime, grapefruit, oranges, um, some some um, I did say fizzy drinks, tomatoes, especially raw tomatoes, and also to a certain extent dark chocolate. So artificial sweetness. What you can do is you can just type on Google, does this sort of food, whatever you're taking, cause me to have overactive bladder, and it will just pop up and let you know. Believe it or not, uh, guys, even in my practice today, I am getting surprised by the things that actually cause overactive bladder. There's so many what you call food groups that causes overactive bladder, and every single day I'm updating my list.
But
And
I assume that is if you're eating large amounts of it, right? Or if you're drinking excessive amounts of coffee, right? It's not like if, because generally anyway, I do tell the women we try to cap within 1, 2 max a day because it is not good for us in general.
correct.
Yeah. Oh, we have one question here. The purpose of abdomen and pelvic ultrasound, is it to check any abnormalities in pelvic floor?
For the abdominal and pelvic ultrasound to a gynecologist or any gynecologist that you're going to, they tend to see if there's any problems available over the uterus and the ovaries. But this transperineal ultrasound, majority of the gynecologists do not know how to do this, and this is basically for the pelvic floor because we look at the opening of the passage, that is what we call the urethra, the opening of the passage from the vagina, from the bladder into the vagina. We look at how the vagina is. We look at all the muscles that are holding and supporting it. During the scan, we tell the patient to push to see if there's anything dropping up and down, and this helps gives us an idea as to what is the symptoms the patient is suffering and how we can help. help it out, help them out.
If I'm going for an annual body checkup, is there any kind of scanning I should request to check the health of my vaginal or pelvic muscle?
No, a majority of the doctors wouldn't do vaginal health, because they feel vaginal health is something that in a certain given time when you're hitting perimenopausal and menopausal, it's something that goes on with it. So majority of the people who are menopause advocates, or those who deal with menopause, or urogynecologists, we tend to look at the vagina and we'll see, oh, this vagina is looking dry, this vagina is looking red, this vagina needs hyaluronic acid, this vagina needs estrogen. What is it that we can offer and we can give to that?
Right.
But if you see a general gynecologist, he'll probably do examination down below, and they might tell you that everything is fine, but you might be suffering from actual dryness
They
that
always
might not get picked up. Yeah.
But what is the test called, doc? So that if
It's a simple examination of the vagina, that when we are doing your pap smear, at the same time we tend to look at the vagina.
okay.
Yeah. So the idea of what we have all been trained for, we are all trained to do this test to see the cervix in order to rule out cervical cancer.
Yeah.
But majority of them, they don't tend to look at vaginal health, because unless there's something really coming out or something really popping out, then there would be a need for you to do so, or to send them towards us.
Okay. All right. Another question. Do you advise women with hysterectomy to insert the ring you mentioned, the pessary ring that you mentioned, to prevent prolapse later in old age?
It all depends on the quality of tissue at the time of the surgery, and what are the changes that has occurred over the period of time. Placing the ring inside is I did a study, especially in women in Penang. 50% of them, they're okay with it. Another 50% of them hate it, because it's something that is there on a constant basis. So by placing the ring, it doesn't mean that it's going to prevent you from getting a prolapse in the future. What can happen over the period of time, you might be comfortable that the ring is there, but as time goes by, the ring might just get pushed out. So unless and until it's a problem, only then you place a ring. Otherwise, you don't place the ring.
Okay. There's from the poll, there's someone who says that they have feeling of heaviness and bulging, that feeling. So would you advise this person to quickly go in and get it checked?
Yeah, that is the first sign. That is the first sign that a woman would come to us telling that I'm feeling some sort of heaviness. Something doesn't feel right. Things are a little bit loose down below, or when I'm completely relaxed, I feel that there is a sort of a button feeling coming from down below. So all these are actually symptoms of pelvic organ prolapse.
Okay.
So when a patient comes to us and sees us in our clinic, especially getting a vaginal examination, we tend to be very, very tense. And that's when you realize how strong your pelvic floor muscles are. Because you will be clenched,
Yes.
clenched to a level that, oh, you're holding your muscles for life. And when you're clenched in that sort of manner, believe me, nothing is going to come out. Right? So the doctor would examine you down below, he'll take a look and say, everything is fine. You don't have to worry about anything at all. And as soon as you leave that doctor's room and you go down to the parking lot, and you're like, "Pah." And the next
Everything.
moment that, that heaviness occurs back again, and so uh, but I guess, yeah, during my training, I learned from I learned from really very great mentors and tutors, and they've told me on how to examine this. Sometimes we are examining the patient the normal way of examining. Sometimes we put them to your left side, we place them on the right side. Sometimes we examine them standing, and we tell the patient to give us a squeeze or give us a push, and only then you catch them. And with these scans also tend to help see the prolapse coming down. If it's a slow sort of a descent coming down, then pelvic floor exercise is something that we can offer.
Right, right. The other thing is this, ladies, the reason why I wanted Dr. Sashi to talk about this is because, again, society, we as women, we get all queasy and like all like about all these things when, we're talking about the vagina and all that. So I want to dispel that. And actually, the sound of prolapse sounds very scary. The sound of when the fistula and all these things, but it's bring you awareness. And I want you to understand that sometimes the procedure can only be 30 minutes and it changes your entire quality of life. So, Dr. Sashi, I want you to tell them that, with the pessary, how long is that whole procedure and what changes for that woman? Tell us a life experience that you've seen women going through.
So pretty much placing a pessary is just like any of y'all walking with your partner into a gold shop or buying that ring that he he promised that he's going to buy for you, or getting a bangle that you really really like. Okay, it's as easy as that. So once we do an examination for and we realize that there is something coming up, I usually place a sort of a diagram to sit and show you how which is the part that is coming up and coming down, or what is the situation is. Placing the pessary, it's all about the right dimension and the right size. That's all it is. Just like buying your partner buying you a ring. So I do this joke among all my patients that I said your first ring is from your partner and your second ring is probably by your gynecologist. So this ring, what we do is we tend to find out the size that is there, and how what is the length of the vagina and the size that is there, and this ring can be just placed inside within 20 seconds, 10 seconds, 10 to 20 seconds. So 10 to 20 seconds, the ring is in. We tell the patients, okay, now I want you to relax. And then we ask the patients to go and pass urine. She's able to pass urine freely.
That's it.
She's good to go home.
Right.
Two things can occur from placing a ring pessary. The first thing that can occur is the patient might not be able to pass urine. That means the ring might be too big for her, or the ring is preventing her from passing urine. So on such a condition, we pull out the ring, she'll be able to pass urine back again. It's as simple as that. The
Right.
second thing with this ring is, like I mentioned to you, holding the pelvic floor for life. So when you place the ring inside, it sits beautifully in a perfect manner. As you go to the car park, and you're walking, and suddenly out of nowhere, that relaxation occurs and the ring drops, because the pelvic floor muscles are the muscles that are holding the ring in place. That's why these ring pessaries are called support pessaries. It's there to support.
Right.
So for those sort of patients, then probably a bigger size ring can be placed inside just to calm things down. Then we go back to the same situation again, whether they're able to tolerate it. Majority of the time, the second day, third day, if the patients are doing okay, then we would leave to them. And how often do we change these rings? We kind of like remove this ring once in probably 5 to 6 months.
Oh,
You can be placed inside there. You don't even need to tell your partner it's there. You can still have sexual intercourse with the ring. its main function is just to prevent the prolapse from coming out.
Okay.
These are ring pessaries that are there, but in due time, what can occur? There are two things that can occur. Uh, I would talk to you all about the side effects. So because all these organs are prolapsing and coming down via the vagina, that tends to cause a lot of vaginal dryness. So when we place a ring back inside, we are we are getting the vagina back to its original form. So these dryness and changes that occur majority of the time may cause a little bit of irritation. Some women may suffer from discharge, but these discharges are actually normal discharges that are occurring due to a reaction that is there from the ring that is inside. Same way when we pierce our ear or we pierce our nose and we wear a bangle and you realize that there are some sort of flimsy sort of discharge coming. There's a similar thing that occurs within the vagina. Unless and until they find it very, very difficult, that they feel that, no, I don't want this, then we think about what is the next thing that we can offer.
Would there be risk of infection?
Usually these rings that are there, they are inert, meaning to say that they're just like your diamond, gold, and platinum that you're wearing. They won't cause you to have infection. But if you do have infection within the vaginal cavity, then and the vaginal cavity is too dry, then there is a small risk of infection occurring. So what we do is, while we place the ring inside, we'll tell the patient to use a cream,
Right.
and this sort of estrogen cream, just to help create back the tissue and keep everything nice.
Right. So one other question from me is that I read in a scientific paper that when you put they are doing this estrogen injection for much older women in their 70s to prevent leakages. Is that something that is that what the medical field is looking at? Is that something that you would recommend people with severe leakages?
So I did mention before, we need to know what type of leakage is occurring, because one leakage, which what we call the stress urinary incontinence, the laughing, coughing, sneezing sort of leakage, this is a structural problem.
Yeah.
The leakage that comes from urgency is a functional problem.
Right.
So structural problem needs to get repaired structurally. That's why your pelvic floor exercises occur to fix, to somehow get a 50-50 remark on the structure. Functional problems, these hormone medications may help, but the thing is with injections that are given systemic, by the time they reach the vagina,
Right.
a very, very small amount reaches the vagina. Even when we prescribe estrogen or these hormone creams within the vagina, these creams are the amount of medications that are there is so minute that pretty much whatever food group that you're taking, which is your soy, has far more higher estrogen in comparison to the estrogen cream that we are giving down there. So the idea is we want local changes. So like if you're placing it within the vagina, it's only that couple of millimeters within the vagina tissue that we want changes to occur, and not a sort of a systemic change. So with these injections, systemic injections, I guess in the future, if you're looking at vasomotor symptoms whereby you have these hot flushes, you're unable to sleep at night, you're having headache, everything, you tend to easily get irritable, and all these sort of patients, oral contraceptive, I mean this postmenopausal patient or hormonal replacement therapy would be the line to go forward for. But for leakage wise, they are doing studies, but nothing of that sort has been proven to be effective so far till now.
Yeah. Okay. One other question. It says, do you suggest women to douche often? I actually been telling people don't douche. It's the worst thing you can do.
So
So you
So
confirm that.
yeah, what has occurred is now at current situation in our research, we are looking at biomechanics and microbiomes that are functioning within the mouth, within the cavity, and also when we place a douche, what we are doing, we're changing. Although all these pH stabilizers that are there in the market that say that it's going to alkalinize it, it does not do what it says. And these are chemicals that you're placing within the vagina. It tends to cause more destruction rather than help
Okay.
improve the pH which is there. So the suggestion that has been there, the time alone suggestion is you use warm water, you wash with normal water, and that would do well. By placing something within the vagina, it tends to sit and cause a lot of what you call irritation and problems. And once these irritations tend to sit and cause changes that are available within there, then you start to experience the other problem that which is dryness, and the dryness
Exactly.
becomes so much more evident.
It's more
So,
worth, yeah,
uh,
definitely.
it's like what we say in the beginning of your lifetime, let's say when you're around 13 14 years old, where you get your menses, all the way down to 30 40 years old, things can be within the placement, whereby even though you do your douching, the skin is able to rehabilitate itself, it's able to rebuild itself. But after a certain age group whereby it's unable to do so, you're pretty much, how we say, a desertification. You're creating a desert within the vagina by douching.
Yeah. And
And
then actually, to be fair, that area is actually very clean. There's no need for all these things, which actually affects your flora and fauna to start with. So yeah, best not to do all that. The other question is, what about panty liners? Should women use with minimum discharge? I think that's a very personal question. So it's up to you. I use it because I don't like having the feeling of just being dirty. But if you wash your panties often enough, I think that's really quite okay.
yeah, what I do want to want to highlight is sometimes the inner garment what you wear, you might be allergic to it. Certain satins, certain silk.
Oh, okay.
So these things tend to what you call cause any sort of cross infection from the part where you pass your motion, bringing it into the vagina, or bringing it into the bladder back again. So sometimes the suggestion, you tend to see quite a lot of these women and models on this beautiful cover of magazines, all wearing really nice, but those
Yes.
things are not really helpful to
Oh,
vaginal care at all. They tend to cause even more problem than
like, I
than
never understood the G string, the string thingy. I know it excites the men, but anyway. Okay.
uh,
To the other ladies, do you have any questions? You can unmute yourself. You don't need to show your face, but you can unmute yourself if you want. We will, it's a good time to ask. So just while waiting for them to ask some questions, I suppose you mentioned several times about the Kegel, the pelvic floor, which is super duper important. Oh, what's the symptom of vaginal wall prolapse?
so I think we touched on this before, but so the how you feel that the sense of fullness down below within the vagina, sense of fullness, feeling of some sort of a button, or feeling of something that is coming out. Those are symptoms of vaginal prolapse. So vaginal prolapse doesn't mean that um, it occurs only when there is a womb inside. If a patient has a hysterectomy done, they can still have the same symptoms. So the symptoms are fullness from down below, some sort of mass coming from down below, or some sort of button coming from down below, or something that makes you feel very uneasy down.
Mm.
Those are all symptoms of pelvic
Is
floor or wall prolapse.
is it normal to have that feeling of like a bubble coming out from the vaginal area? Is that something to be?
Depends when, Karen. Are we looking at it during the time of menses? Are we looking at it at the time of post intercourse? Are you looking at the time every single day? It all depends on it. If at the time of intercourse, there are situations where patients can have some sort of gas, sort of farting coming out of the vagina. That is common. Majority of the time, that is caused for air pockets that get trapped within, and this may be a symptoms of going into a different topic altogether. Symptoms of sexual dysfunction, whereby air pockets are forming within during the time of the friction inside, and then they are popping out and coming out. But it's also symptoms of pelvic floor dysfunction, where Kegels exercise majority of the time helps with that. But
Okay.
bubbles, yeah, really depends. Really depends. Also.
I have to ask this question on behalf of a client. She
Mhm.
has severe painful bladder, painful bladder syndrome.
Bladder syndrome.
Yes. And she's now in acute pain and they are doing all sorts of things to her. So can you explain to our audience what it is, how it happens, what can we do?
Okay. So, Karen, this is a total.
I know.
It's a very, very big, very, very big topic. So when we talk about painful bladder syndrome, it's a problem whereby the nerves of the bladders is excited.
Okay.
All right. So when the nerves of the bladder is excited, the excitement may be caused due to inflammation. That means some sort of over the years infection or some sort of problems that has caused it to occur. Or it can be the body that is fighting against the cells within the bladder, causing them to have that problem. Or it can be due to um, over the years of overactive bladder that has gone into hyperdrive. So with this sort of bladder pain syndrome, majority of the women, they suffer from all the symptoms of urinary incontinence as well as urinary tract infections altogether. It comes as a bundle job. So pain when passing urine, unable to control your urine. Once you pass urine, the bladder is still contracting, so it's causing constant pain. Um, there is urgency to a limit that one cannot sustain that. And so this for us is one of the toughest problem to sit and deal with. Majority of the time, we have to angle these patients from different points of view. We take a detailed history to rule out and to see to it as to what was the trigger and causes. And let me be open about this to you all. There is no absolute reason as to why this occurs. This can just occur to anybody.
Okay.
So when it does occur, majority of the time, these patients will end up in a GP. They'll see a GP. They'll give them medication. They'll feel fine with the medication for 5 days, and then the pain will go back. And then they'll go to another GP. They'll take medication again. The pain will come. The pain will go. So they'll think that they are going through urinary tract infection, which is being recurrent, but it isn't. What's happening is the bladder is inflamed and the nerves are being involved. So the sort of treatment that we need to give them is we need to counsel them. There's behavioral therapy involved. We need medications to calm the bladder down. We need medications to calm the urgency down. We need medication to calm the pain down, as well as treatment per se for dealing with this. So one of the treatments that we look into is a cocktail of some steroids, some hyaluronic acid, where we instill it into the bladder, and the patient, and what the patient has to be, she has to be on back, on her left, on her right, as well as on her tummy for close to 1 hour. So we get the medication all involved in and around the whole bladder. And some they have to go through close to around 4 to 6 cycles of this weekly for the first month, and then over 1 month monthly then after. And that is to recreate that skin back within the bladder. With that, patients can still come back to you with pain if they take something that is wrong, or they take one of their triggering factors. It can be very, very devastating for them. And in comparison to that, even the majority of the urologists, when they come across, what they do is they do a camera test and they look at the bladder and they realize the bladder is all inflamed and it's constantly inflamed. And the treatment that they can offer may be helpful, but it's actually a sort of a multidisciplinary sort of treatment that we need to offer in order to solve this problem. And it's not something really easy, because the symptoms are not going to get sorted within the first meet or the second meet or the third meet. It takes time. It takes sometimes the symptoms can go on even with treatment for 9 months before total recovery. We call that the toughest to deal with in our practice.
Okay. All right. One question. What's about vulvodynia? Is there something that can be like procedure to treat?
Yeah, so this is currently another group of women with our current younger group of women are suffering from that. So vulvodynia is painful sexual intercourse. So again, it can be a structural thing or it can be a functional thing. If it's a structural defect that is there, whereby the space is too small, or the space is too tight, or the muscles inside are too tense, all this can really cause a sort of a problem for a woman, because she'll have painful sexual intercourse and she'll say, no, I'm not going to get anything done. Vaginal examination, majority of the time, is the way we move forward, where we'll take a look and we'll see younger age group women who have never been sexually active before. They can have small tissue that is bridging within the vagina, and this may be the reason of the call for the pain, and you can just cut the tissue off and the pain is sorted off. So that all this is for the functional problem. When we, sorry, structural problem. When you're talking about functional problem, we need to dig in a little bit deeper if there's any trauma, psychological trauma that has dealt with a lot of behavioral therapy, talking to them, telling them that everything is all right, there's nothing wrong with down below, giving them some sort of pain relief and painkillers over there, getting the partner involved in this, having joint counseling on this, and these are the things that we'll be able to help deal with.
Okay, good. All right. Any last few questions before we let the good doctor go for his Sunday family time? Guys, I hope you all learned something from this. Please send some love to Dr. Sashi, okay? He spent 2 hours nearly with us, and it's his time, it's his Sunday with family, and he's doing this for us. So please, thank you so much, good doc. I really appreciate this.
Yeah.
I hope you all learned something today. And if you still have questions, please, you can write to me. I will address it with doctor himself. But you can find him. He's now at Gleneagles Hospital. You will see him, make an appointment to see him if you need to. Most importantly, don't be shy about this. This is something that we need to address. And the more conversation we have, the more awareness is what I'm trying to achieve here. So I hope you all write 3 things in our chit chat group, what you have learned, so that those who didn't attend will at least take away 3 things. So please, mention the 3 things, and any 3 things that you got away, please on the chit chat group. And Dr. Sashi, again, thank you so much for your time. And I hope that I'll get you to bring you over for our 1-hour events very soon, next year.
Yeah. So Karen, I have to thank you too. I remember when I came back after completing my studies, I realized that this was a problem, and the taboo behind it is really, really strong. And you don't feel shy to sit and talk about it, and you feel that, let me go and see my gynecologist on this. And majority of the time your gynecologist might be suffering from the same problem too, and they'll say, this is something that occurs and you don't need to do everything about. So when Kevin actually called me and spoke to me about this, I was very, very passionate. As you can see, this is something that a lot more women are suffering from, and they are open about it in European countries, in America and in Australia. But here we tend to be like, this is something that we need to suffer in silence, and I believe you should not suffer in silence. If there is, just a few twerks or something that probably Karen can sit and help you out with, or something that I'll able to help you out, and you can go back to doing what you constantly do, whether you're your young age or your middle age or your old age. That is something that will really benefit and keep you active with, and that is actually the motto and the spirit on what we are doing here.
Thank you so much, Doctor. Okay, ladies, enjoy your Sunday family time. And until 2 weeks from now, I'll see you soon. Thanks, Doc. Thank you.
Bye. Bye.